All right, welcome in everyone to the deep dive. We're going to be doing taking a pretty detailed look at mitral valve prolapse today. We're going to call it MVP,
Yeah.
and we've got a really interesting cardiology document that goes through how it's found, how it's diagnosed, and how it's managed.
Yeah, we're going to take a really deep dive into MVP,
Yeah.
looking at, what causes it, how we find it in practice, what investigations we do, and then, what the kind of long-term implications are.
Yeah, so it jumps right in and it talks about this patient who presents with a late systolic murmur at the apex,
Okay.
radiating to the axilla.
Right.
Now, apart from that, they had no other peripheral stigmata of cardiac disease, but they did have joint hypermobility and skin hyperelasticity. So, based on all that, the primary diagnosis was mitral valve prolapse with a secondary connective tissue disorder, most likely Ehlers-Danlos syndrome.
So it sounds like it could be Ehlers-Danlos syndrome.
Yeah, and so that's one of the conditions that it lists. It says other associated conditions are, well, it mentions Marfan syndrome, first of all,
Yeah.
and it says it has a very high association, as in 90% of patients with Marfan syndrome will have MVP.
Right?
Yeah. It also lists osteogenesis imperfecta and polycystic kidney disease as other associated conditions.
Hmm. Yeah, and it's interesting, isn't it, that,
Mm.
this heart condition can be associated with all these other seemingly completely unrelated conditions.
Yeah, yeah. I mean, it's something to think about, right? When you see MVP, especially in younger people, could there be something else going on, some kind of connective tissue disorder?
Absolutely, yeah. It's a reminder that, sometimes a seemingly isolated finding, like in this case a heart murmur, could actually be a sign of a much more widespread condition.
Now, just to kind of give us some context, the document goes through some of the other causes of systolic murmur. So, just to remind you, a systolic murmur is the sound we hear when the heart muscle is contracting. And it says a pansystolic murmur in the mitral valve area could be due to mitral valve degeneration, rheumatic heart disease following rheumatic fever, or secondary mitral regurgitation, perhaps following something like infective endocarditis.
Right.
So there's a lot of things that it could be, but it's very subtle, I guess, what kind of murmur you hear and when in the cycle you hear it.
Yeah, it's incredible, isn't it, how these really subtle differences in the sounds can give you a really clear idea of what's going on inside the heart.
Mm.
Like, for example, that late systolic murmur that we talked about in that initial case, that's a really classic sound that should make you think of mitral valve prolapse.
Right, right. And it also mentions a hyperdynamic systolic murmur following a hypertrophic obstructive cardiomyopathy, or HOCM,
Yeah.
as well as a systolic murmur in a ventricular septal defect due to a bicuspid aortic valve. So lots of different things that it could be. Now, in terms of investigation for suspected MVP, it says full patient history, specifically looking for past complications related to Ehlers-Danlos in this case. Yeah.
Comprehensive blood work, including genetic screening, ECG, and chest X-ray,
Yeah.
and then echo and cardiac MR scan to assess for other complications of mitral valve disease.
It's really important to get a full history, isn't it? Especially in cases where we think there might be an underlying connective tissue disorder, like Ehlers-Danlos.
Right.
So, asking about past complications related to that could give us some really important clues.
Yeah, and I imagine the genetic screening is quite important there too, to try and pin down whether there is a specific connective tissue disorder, whether it's Ehlers-Danlos, Marfan, whatever.
Yeah, absolutely.
Um, Now, in terms of the kind of the standard heart investigations that we're all used to,
Yeah.
the ETG, the chest X-ray.
Yeah.
I mean, obviously the ECG is just looking at the electrical activity of the heart, and the X-ray is just looking at the shape and size of the heart. But the real gold standard, I guess, is the echo, because that actually allows you to visualize the mitral valve and see if it's prolapsing.
And, to what degree it's prolapsing, if there's any regurgitation.
Yeah.
And then, sometimes they'll do a cardiac MR scan as well, just to get a more detailed picture of the anatomy and the function of the heart.
Yeah, that's really interesting. Now, in terms of long-term management and follow-up, what does the document say about that?
Well, it says regular follow-up in the cardiology clinic with echocardiography to monitor for decompensation,
Okay.
and then regular ophthalmology follow-up due to the risk of lens dislocation associated with potential Ehlers-Danlos.
Hmm.
So it's interesting, again, how there's that connection with the eyes, because of connective tissue disorder.
Absolutely. Yeah. It's a good reminder that, Seemingly unrelated symptoms can be really important clues.
Yeah. So now let's talk about the actual, the specifics of mitral valve prolapse. It gives a definition and talks about how it can be classified.
Mm.
So it says that mitral valve prolapse generally has a benign natural history, but has the potential for serious complications, including infective endocarditis, thromboembolic events, cerebrovascular accidents, need for mitral valve surgery, and sudden death.
Wow. Yeah.
Yeah, most of the time it's not too much of a big deal, but there is the potential for things to go wrong.
Yeah, but it's good to know, I guess, what the potential complications could be.
Right. So, it says that it can be classified as primary or secondary. So, primary MVP is caused by myxomatous degeneration, and it says that's a thickening of the spongiosa layer with proteoglycans.
Okay.
And this affects the valve and the chordae, leading to a thickened flaccid valve bulging into the left atrium.
Right, and it's this myxomatous degeneration that causes that kind of classic appearance of the mitral valve when you see it on an
Oof.
echocardiogram, where it's kind of thickened and floppy and billowing back into the left atrium.
Right, right. And then in terms of secondary MVP, it says that this is associated with identifiable connective tissue disorders like Marfan syndrome, Ehlers-Danlos syndrome, osteogenesis imperfecta, polycystic kidney disease, and other non-mucous mitral valve disease.
Okay, so secondary MVP is basically when the prolapse is caused by one of these underlying connective tissue disorders or other conditions.
Right, right. So how do they actually, diagnose it then? What are the things they look for?
So if you suspect MVP, you're going to be listening out for a dynamic systolic click and a mid to late systolic murmur, best heard at the apex. And then this is confirmed with echocardiography.
Right. And I guess in the real world, I mean, the way that they often pick it up is, somebody's listening to your heart and they hear this murmur and they say, oh, that sounds a bit like MVP.
Exactly.
And then they send you off for an echo and the echo confirms it.
Precisely.
What are the main differentials that they list?
The main differentials listed are bicuspid aortic valve, atrial myxoma, mitral regurgitation, or MR, and hypertrophic obstructive cardiomyopathy.
Right. Okay. And so then what about prognosis and risk factors?
So the prognosis for the vast majority of patients with MVP is excellent. Often no lifestyle modifications are needed, and conservative follow-up is sufficient. Higher risk groups include those with moderate to severe MR, depressed left ventricular function, increased end systolic diameter, atrial fibrillation, left atrial enlargement, age greater than 50, valve thickening greater than 5 millimeters, and a flail leaflet.
So it sounds like, most people don't really have too much to worry about if they have MVP.
Yeah, exactly. For most people, it's a relatively benign condition.
Yeah. But there are certain groups of people where they do have to, watch it more carefully.
Yes, definitely. And it's important to identify those individuals who might be at a higher risk of complications.
Right. Now, in terms of arrhythmias and anticoagulation, it says that isolated MVP is not associated with excess atrial or ventricular arrhythmias, but MR is. Atrial fibrillation management follows standard guidelines, including anticoagulant prophylaxis. And novel anticoagulants are not contraindicated. So I guess the message there is if you've got atrial fibrillation and you've got MVP, you can still take the newer blood thinners.
Yeah, exactly. There's no reason why patients with MVP or MR can't be treated with the newer anticoagulants if they need them.
Right. And then finally, surgical intervention.
Yeah.
It says that this is guided by symptoms and echocardiogram findings.
Okay.
Pre-surgery, cardiac catheterization is done to assess for coronary artery disease.
Right.
And then they usually do a transesophageal echocardiogram to assess valve reparability,
Yeah.
which is the preferred approach. So they would rather repair the valve than replace it.
Yeah. Makes sense.
But mitral valve replacement is reserved for unfavorable anatomy.
Okay.
Minimally invasive surgery with a right mini thoracotomy may be suitable in the absence of coronary disease. Right.
And then it mentions that percutaneous treatment is currently limited to mitral clips for suitable anatomy and if no surgical option.
Yeah.
But they say percutaneous mitral valve replacement may be a future development.
Right.
So I guess what they're saying is, at the moment, if you need a mitral valve replacement, you pretty much have to have open heart surgery.
Yeah.
But, there's a lot of work going on in the background to come up with a less invasive way of doing it.
Yeah, it sounds like there are some really exciting developments in the field of percutaneous valve interventions.
Yeah. So there you have it. That's our deep dive into a mitral valve prolapse. I guess The main take-home points are that it can be caused by changes within the valve itself, or it could be part of a wider, systemic condition affecting the connective tissues.
Absolutely.
It's diagnosed with echocardiography primarily,
Yeah.
and then the management can range from watchful waiting to surgery. Yeah, I think what was particularly interesting for me was that initial case and how those seemingly unrelated clues like the joint hypermobility and the skin hyperelasticity could actually be really important in pointing towards a heart condition. It
I
just shows you can't always look at things in isolation. You have to think about the bigger picture.
Yeah, and it makes you wonder how many, you know, seemingly insignificant little physical findings that we all have
Yeah,
are actually clues to something else going on.
absolutely.
Where all these complex systems all interconnected.
Yeah.
Anyway, thanks for joining us on this deep dive. It's been a pleasure having you.
Thank you. It's been fun.
We'll see you next time.
See you next time.